Good morning, everybody, and welcome again to all of those who put in some hard work yesterday, including some of you in the afternoon and evening. And for those people joining us for this as a webinar, very welcome. So we've got some very interesting and I think enlightening presentations that we'll just be listening to. We'll run through those presentations in sequence without questions immediately after the presentation. So if people could just keep a note of their the question they want to ask, we'll have some time for questions at the end of the session. If you want to write your question into the chat function of Zoom, please do that, and we'll have facilitators who will be looking out for those questions. Or as we approach the question and answer session, begin to put your hand up so that we can identify people who want to ask a question in the final piece of the first session. We had some interesting discussions yesterday. There's clearly lots of work to do in this arena of universal health coverage. For somebody like me who is much less familiar with Nigeria, there was clear recognition of some of the realities of achieving UHC, but it was fantastic to be with a community that displays all the optimism and enthusiasm and energy that everybody did yesterday, and which I've come to associate with at least my work also in East Africa. So our focus really by the end of this morning is to come up with some high-level aims that we all feel we can share and endorse, and for that reason we'll have some breakouts, get feedback from the breakout groups from yesterday, have some more discussion, but to further inform those discussions, we'll start off with the presentations. And as I said, we've got 5 of those. So if we're ready, it'd be great to welcome Robert Yates, who's Executive Director of the Centre for Universal Health at Chatham House in London, a think tank I think many of you know, and he's going to talk to us about how can Nigeria finance universal health coverage. So if everybody's ready, we'll go for Robert.
Great, thank you very much indeed, Mike, and greetings from Chatham House. Well, actually my study in Wandsworth, of course, because we're in lockdown still at the moment, partial lockdown in London. But yes, I'd like to talk to you about health financing for 10 minutes, a topic that came up quite a lot in yesterday's discussions. And if I just try and share my screen, hopefully you are seeing some slides now. Okay, not? Yeah, right, with that. Yes, how can Nigeria finance universal health coverage? A huge topic and one that I'm sure is exercising a lot of you. And first of all, I think it is important to define what we mean by universal health coverage. This is the simple definition that all people receive quality health services they need without suffering financial hardship. Notice there's nothing about insurance in here. You know, people often associate UHC with health insurance, but it's all about people just having financial protection from when they access health services, and of course everyone being covered. And this is very important because I think that UHC is really fundamentally about rights and equity. It's being universal. It means that literally nobody is left behind. And you know, of course, we're seeing in the COVID crisis how important it is for public health that sectors of the communities like refugees aren't left behind. So it means everyone. Secondly, that services are allocated according to need. We're not saying that everyone gets the same amount of healthcare, but some people objectively need more health services than others. So young children and pregnant women and disabled people and people, say, requiring palliative care, they need more healthcare, so they should get it. Thirdly, it's about a health system which is financed according to people's ability to pay. If you're having a situation that everyone gets the health services they need, well, then clearly you need a financing system where richer people pay more than poorer people. Otherwise, only rich people will get the health services. And so that all really boils down to this idea of healthy, wealthy people cross-subsidizing services for the sick and the poor. Now, what does this mean, therefore, for what are the best financing mechanisms to reach UHC? And here it is actually pretty straightforward and very clear now. I'd say about 20, 30 years ago, there were big debates about the role of private financing and public financing. And you even had the likes of the World Bank and IMF about 20 or 30 years ago saying that it was legitimate to charge healthcare user fees. But all this has changed now. And there is this realization around the world that a market-driven, privately financed system, people buying and selling health services, will never result in universal health coverage. And quite simply, that's because you won't get the cross subsidies. If you want to have a situation that the healthy, wealthy subsidize the sick and the poor, the state has to force people to do that. Now, this has implications for different types of financing mechanisms, because obviously user fees, which is the way that you trade health services, is the worst way to finance a health system. And you have WHO in this pandemic now encouraging countries to scrap all healthcare user fees. Now, interesting, private voluntary insurance is not really that much better, because the rich will always try and sort of opt out of subsidizing the poor. And there are only one or two countries that are really heavily reliant on private voluntary insurance, the United States and South Africa, really. And clearly that type of system is very inefficient, it's ineffective, it doesn't reach universal health coverage, and it's fundamentally inequitable because the poor tend to get left out. So really, that means that public financing is the only way to reach universal health coverage. And there your two main mechanisms are financing out of general taxation, like we have here in the UK and a good number of countries around the world, and also social health insurance contributions. But it has to be compulsory and progressive. The rich must be made to pay more in. And because it is compulsory like that, it's basically a public financing mechanism. So, social health insurance and taxation actually aren't that different. And most countries mix them anyway. So I think it's simpler really to just refer to public financing. And this was a point that Gro Harlem Brundtland made last year at the UN high-level meeting on UHC, that if there's one lesson the world has learned, it is you can only reach UHC through public financing. And I think, that this is the consensus now. All the big agencies are saying the same thing. And so the issue in Nigeria is, how do you publicly finance the health system? Because looking at the situation in Nigeria, you can see that, if the idea is about reducing out-of-pocket spending, which we know is the worst, and really public spending is what you're required to do that, these are all the countries in Africa in 2016. And you can see, the situation in Nigeria is that, it's pretty much the lowest public health spend as a share of GDP and the highest out-of-pocket spending. We heard this repeatedly said yesterday. And of course, in a situation like this, you're looking at a lot of people being excluded from the health system. So the trick is, how do you move down that curve? And really, you need public financing to do that. And this really does, I think, demonstrate as well, that Nigeria over recent years hasn't been fulfilling its commitments, whereas, many of its competitors, they have been increasing their public spending. In Nigeria, it's been sort of going down, and there's only about 0.5% of GDP, which I think is the second lowest in the world. I think South Sudan is lower. So it's only up from here. This is the opportunity to increase public spending now. Now, how do you do that? And I think there's this recognition that given the magnitude of the task, and often the different ministries of finance to come up with the money, you need to go for the politicians. It's politicians and heads of state. We heard former Governor Mimiko from Ondo yesterday saying that, how he had introduced universal free healthcare. It's politicians who make the difference. And so Dr. Tedros is very much working with politicians to encourage them to increase financing. And it's interesting, that this is Thailand wasn't doing particularly well when its GDP was similar to Nigeria's today. Prime Minister Thaksin came in after the Asian financial crisis, introduced publicly financed UHC, and Thailand had some of the best health systems in Southeast Asia now, and is coping very well indeed with the COVID-19 crisis. Another country that is showing inclinations like this is Kenya, where President Kenyatta announced about 3 years ago that he was making UHC a priority, and WHO is advising President Kenyatta. And in fact, they've started off with piloting universal free services in 4 counties, scrapping user fees, largely not taking health insurance contributions, but going for a tax financed approach. So the big question is, sort of in the midst of, COVID-19, is this the appropriate time to be having this conversation with President Buhari and say state governors in Nigeria? And I would say, yes, it definitely is. You might think counterintuitively that in the middle of a massive crisis that's battering public financing, this will be the last thing that politicians want to hear. But surprisingly and interestingly, this is the best time, because this is a crisis, a health crisis requiring immediate action from the head of state, particularly around giving people access to health services and giving them financial protection, often to protect their jobs and their livelihoods. And there is this demand from the population that everyone is included. No one's going to want to, say, get left out when an effective vaccine comes along. And there's great pressure to act quickly. Look around the world, politicians really talking up what they're doing and acting quickly. And again, there's a real precedent for this. In China, after the SARS epidemic in the early 2000s, the Chinese realized that they'd allowed their health financing system, if you look at the graph on the right here, to become dominated by private spending. And this had resulted in a very weak health system that hadn't coped with the crisis. And so this was the catalyst for rapid re-socialization of the health financing system in China. And that involved, I think it's involved about $600 billion of tax financing each year now to reach 96% coverage in China. South Africa is a country in this crisis where President Ramaphosa is saying that he's going to launch the national health insurance reforms in South Africa off the back of the COVID crisis. It's going to be tax financed and it's going to cover the entire population. And we're seeing leaders all around the world taking similar actions. The big question is it going to happen in the United States, where, of course, this is going to be such a hot issue in the upcoming presidential election. And in a recent town hall meeting, Hillary Clinton actually used these words, don't let this crisis go to waste, and encouraging Joe Biden to basically run on a UHC ticket and fast track the United States towards universal health coverage. So the big question is, will this be the time for Nigeria to go from that very low public spending to accelerate UHC reforms? And I think, that the opportunity is ripe, and it's all a matter of, how do we get the messages to the right people at the right time? So just to conclude, yes, we are obviously the biggest health crisis in over a century, and people are desperate. They're fearful. They want their leaders to take action, particularly around giving people access to health services and financial protection. So I would say learning from history, including the history of the UK. I mean, our NHS came out of the rubble of the Second World War, the same with the Japanese health system. So in the middle of a crisis, now is the time to be pitching UHC to political leaders in Nigeria. And we at Chatham House and as part of the LAFIA consortium are very, very keen to support all of you in that process. So if you want us to talk to any politicians about the merits of this strategy, do please get in touch. Thank you very much.
Great, thank you very much, Robert. And as I said, we won't have now, but there was lots of information in there, and I'm sure people will want to come back to it. So please keep your questions, put them in the chat, write them down, and we'll get to you later. And thank you also, Robert, for sticking to time. And I'll be having to interrupt the panelists' talks if they do run on, but we'll move straight on now to Dr. Nneka Orji, who's a senior health economist with the Federal Ministry of Health in Nigeria, and who's going to talk to us about accelerating UHC in Nigeria and what the ministry sees as opportunities and challenges. So over to you, Dr. Nneka.
Yes, so good morning, everyone. Sorry, a couple of minutes. I'm trying screen. Okay. So just to confirm, is it showing now?
Yep, it's showing.
Yes, it is.
Right, okay. So thank you very much, and good morning, everybody. So we're going to be discussing issues around accelerating universal health coverage in Nigeria. What are the current challenges and the opportunities?
Sorry, excuse me, Dr. Nneka. If you're able to put it into full screen, that might help people. Thank you.
Okay, right. Better now?
Perfect, thank you.
Right, so we'll be talking about accelerating universal health coverage in Nigeria, what challenges we've encountered, and what are the possible opportunities that we see. And so this outline will guide the discussion as we move on. So just as a bit of background, we found out that in the last 20 years or more, Nigeria has made several efforts to accelerate or implement universal health coverage interventions by either committing to UHC goals or signing on to UHC pacts or even protocols, both at the national, regional, and global level. So just a couple of the interventions that we have tried to implement in Nigeria, working towards UHC, the MDGs. Currently we're on the SDGs. We also have the PHC Under One Roof initiative, PHC revitalization, and the Saving 1 Million Life project, which has just come to a close. We also have the ANRIM project, which is around nutrition. And in the past, we've had the NHIS MCH intervention and several others. And as a strategic document, we also have the strategic health development plan. Currently, we have the second strategic plan, which is going to be reviewed as, going on midterm implementation. That document is anchored on the National Health Policy, which was also discussed yesterday, which is focused on 15 key priorities. And most recently, we had the National Health Act, which also contains the Basic Healthcare Provision Fund, which was also mentioned yesterday. And most importantly, in 2018, Nigeria joined the UHC partnership, which supports the development and implementation of sector UHC communication strategies in line with country priority and country agenda. So you agree with me that we have walked around and yet we're still where we are. So just to have a peep at the current UHC indicators in Nigeria, looking at the global standard and juxtaposing that with what currently obtains in Nigeria. So looking at the general government health expenditure as a percentage of the GDP. So the global benchmark is 5%, but Nigeria is still at 0.7%. Looking at the Abuja Declaration, not minding that this declaration was made in Nigeria, and Abuja precisely, Nigeria is still doing very badly at 6.6% as against the 15%, which is the standard. Our out-of-pocket health expenditure is not enviable. The global standard is around 30 to 45%, 30 to 40%, but Nigeria is, as a 2017 National Health Account report, we are at 77.5%. And just to say that the preliminary reports that we have from the 2018 health account study is even giving us a higher figure. And then for the per capita spending on health, Nigeria has not done well at all. So we continue to have the inverted pyramid where we spend more on curative rather than focusing on preventive care or primary health care, which is the main strategy for us to fast track UHC. Again, when you look at the PHC spending, so you find out that most of the spending on PHC services would even happen outside the PHC system, whereas we have low spending on PHC services within the PHC centers or PHC system. So we have a huge gap of 84% to deal with. So that means we're not prioritizing primary healthcare as a strategy for advancing UHC. And then if you look at holistically, financing healthcare in Nigeria, you see that out of pocket is topping the list. This data was drawn from the National Health Account as at 2017. Like I said, the preliminary report from the 2018 analysis is even higher. So it's showing us that even the health insurance coverage, which some people have argued could help us leapfrog our aspirations as a country, we've also not done well in that regard. So if you look at, the OOP is growing fast, whereas public financing is growing very thin at 18%. That is not very good for us as a country. So we've been able to, going through all of this, we've been able to identify key issues that is actually impeding our accelerating UHC in Nigeria. So topmost amongst our findings is the fact that UHC has not been made a political priority. This resonates with all of the suggestions and discussions that had happened both yesterday and from Robert's presentation this morning. So we've not made health a political priority. It's not topping the political agenda. We have inefficient financial flows. Our financial flow system is erratic and unpredictable, and this does not tell well with, it doesn't go down well with financing our health system. Again, the high out of pocket, and then the way our health budget is designed, it's like it's in silo, it's in isolation, not looking at other systems that could impact on the health system. And also having to deal with the complexity of our health system, which is fashioned around our political governance system. It's really very complex to deal with. Then the current national health insurance status is also not good for the system. So in the last few years, and still obtainable, we've noticed that there is a low absorptive capacity. And this is the reason why I put inadequate financing, below the list. So for me, I don't think inadequate financing is the problem, because if we have a low absorptive capacity, we shouldn't be talking about inadequate financing. We're not using there is huge inefficiency within the system, and we're not using what we have for us to say there is inadequate financing. Now, donors and other foreign implementing agencies, they've played massive roles, in our health system. So most times their roles and their priorities are not aligning with country focus. So for us, that's a big issue that should be talked about more deeply. Accountability accountability frameworks and strategies are not adequately they're not targeted, and they're not, they're just not working, And then the private sector is one area that we have failed to tap from what it has to offer. So looking at all of this, the question is, can Nigeria actually reverse the trend with the OOP growing fat and public financing growing thinner? So, let's see how that goes. So we're able to outline a few opportunities, for us to move UHC forward in Nigeria. But few things we must take into consideration is that UHC is entirely aspirational, and that is what it is. There's no hard and fast rule about UHC. So, and the fact that it's one of the core targets of the SDGs. So that will mean that UHC is not a standalone. It's also hinged on some other multi-sectoral strategies that health people will need to look at and work more closely to achieve. So UHC, we should understand, is not just about financing, although financing is critical, but we must look beyond financing if we have to achieve UHC. There are other health systems and even outside the health system bottlenecks which need to be looked at. UHC is a political choice, and we need to recognize that and push for it to be top on the political agenda. With that, we may be able to galvanize political commitment as well as increase the financing and do that efficiently. So we also need to look at other political dimensions of UHC. The relationship of government with other stakeholders within the system. That's why I said we must have start having open discussion with the private sector players. There's huge mistrust between government and the private sector. We need to address that by having open discussion. And this was mentioned yesterday, and I think Robert mentioned it again, but I think more specifically, Nigeria needs to start looking at policies for cross-subsidization if we really need to work on the level of our OOP. And not just that, there are people that we're making these decisions for. There are citizens of this country, and they're never, on the table for where these discussions are happening. So citizens must be made part of the discussion if we need to move forward. Trying to conclude, I want to say that the gold standard for UHC must be public financing, not just public financing, but it has to be efficient public financing strategy. And our donors need to be guided to align with country needs and country focus. So the discussion and the relationship between government or countries and donors needs to change. And going forward, we need to start building targeted partnerships for UHC to move forward, especially when it has to do with the multi-sectoral approach that we are talking about. Again, citizens and beneficiaries need to come to the table where discussions are happening. And we need to start educating people that OOP is a huge, high OOP, not just OOP, but catastrophic OOP is a huge barrier to advancing UHC in Nigeria. So not just at the federal level, but we need to drill down to actors at the state and the local government level to provide that support and technical assistance that is missing there, to help them redefine and realign their UHC readiness and UHC focus, such that they are able to take charge of the health of their people. The discussion that happened yesterday, it was mentioned that some commissioners of health, some governors don't even know what is written inside the their state strategic plan. So I think going forward, we need to address that by providing that support and guidance for them to understand the content of the plans and their roles in making sure that the plans are well implemented. So we can't run away from this. Within the health system, within the UHC space, there's a huge power play, amongst different stakeholders. I think that needs to be strategically addressed as well. And accountability strategies and focus should be open and collectively defined as well. Again, I say there must be mutual accountability between donors and the government of Nigeria. Another critical point is to ensure that roles and responsibilities of different actors within the health system, they're very critical. They are supposed to be clearly defined. I don't want to go into it, but we learned lots of lessons from implementing the basic healthcare provision fund. We also need to clearly outline strategies for strategic purchasing, who is purchasing what, who is regulating what, and all of that. Well and clearly articulated laws and policies are imperative. Lots of lessons from implementing the basic healthcare provision fund. So I don't want to continue to take our time, but I think the key points here is to say that awareness creation at all levels for different stakeholders is very important. The political support.
Dr. Onyeka, please, if you could really rush through this slide.
Yes, I'm just finishing. So we need a national UHC strategy and framework, very important for us to move forward. And also for CSOs to take ownership and provide that available, the necessary nudge for government to do the right thing. Mainstreaming health in all sectors, like I said, a multi-sectoral approach is what is needed at this point. Health system reforms to strengthen all the building blocks of the health system, very, very, very important. Thank you very much for listening and thank you for your time.
Great, thanks very much, Dr. Onyeka.
Yes.
I'm always hesitant to interrupt somebody from a federal government, but lots of important messages there. The next, I might be a little less polite as we've eaten in a little bit to our question time. So it would be great to have some questions. So I will keep the next speakers to 10 minutes or a bit under if you can manage it. And you can post questions in the Q&A part of the Zoom platform that you can probably see in your taskbar at the bottom. But let me now hand over to Professor Oyegoreje, who's Professor of Psychiatry, and I think everybody on this call probably knows him, and he's Director of the WHO Collaborating Center for Research and Training in Mental Health in Ibadan. But over to you, Oye.
Can my slide be seen?
Yes, we can see them.
Okay, thank you very much, Mike. Good morning, everyone. Many thanks for the opportunity to contribute to this important topic. My intention over the next 10 minutes or so is to highlight some of the barriers to the achievement of UHC. I will be focusing specifically on supply side barriers, even though I do realize that demand side barriers are also quite important, especially in the context of mental health care, which is what I'm going to be particularly paying attention to. These barriers are not by any means, of course, limited to mental health care alone, pervade most areas of health need, but mental health probably best exemplify the impact of these barriers. Mental health is actually one of the most neglected areas of public health, as can be seen on this slide, even though more than 28% of years lived with disability is attributable to mental, neurological, and substance use disorder. Many of the major disorders or mental health disorders do not, persons suffering from them do not receive adequate care. In fact, sometimes not care at all. As you can see on that on the side of that slide, that large proportion of persons suffering from these conditions do not receive treatment around the world. Of course, with the most astonishing rate of treatment gap being found in low and middle income countries. I'm trying to see whether I can change the slide. All right, so things are changing though. There is now increasing acknowledgement that there's no health without mental health, and that global developmental goals cannot be achieved without adequate attention to mental health care. And this is reflected in the fact that the SDGs now have specific targets for mental health service, including promotion of mental health, prevention of and treatment of substance abuse, and what we've been talking about in the last day or so, which universal health coverage, which of course covers mental health care as well. But this enthusiasm or commitment around the world is not so much reflected in what is happening in Nigeria. And these are the barriers which I said I was going to focus on, these supply side barriers are the ones that constitute the main problems. And I define these barriers are the ones that restrict access to adequate care. Main examples of them, again, we've gone through some of these in various presentations in the last day or so: lack of policy or poor implementation of policy, poor funding, and that's also been reflected in what's been described or mentioned this morning. The scarcity of specialists, and even though that might not be a problem, but there is the problem that you then have inefficient primary care where non-specialists are in abundance. And then, of course, pervasive stigma. The policy environment is a particularly disappointing one in Nigeria. The current Nigeria mental health policy, which was adopted at the 56th meeting of the National Council of Health in 2013, has not been implemented. The one before that, which was adopted in 1991, was equally not implemented. So that's a policy, but it's not even complemented by a program of or a strategic plan about how to bring about the achievement of the various aspirations in the policy. We're still using laws that were handed over by colonialists, insanity laws they are called. These are laws that are really out of step with modern mental health care. Even though several attempts have been made in the country to have modern era mental health, over the past 20 years, we've been making attempts to get new laws to be passed, but this has not succeeded. Meanwhile, really embarrassing human rights abuses of persons with mental health persist in our country. Poor funding, both Robert and Neka this morning have also mentioned issue about poor funding, inadequate, which of course translated to a payment out of pocket. And for mental health conditions, which often require long-term care, this often means that families are driven into poverty because of the need to provide care for the members of the family who may have a disorder, because we do not have any coverage for those who are unable to afford care. Scarcity of specialists. Nigeria has about 250 psychiatrists and even fewer specialists in other areas. This is, of course, means that we can rely on specialists to provide care, but that's actually probably not a problem if we had an efficient primary care setting or primary health care service where we can draw on the skill of the non-specialists there. But a large proportion of primary care clinics in Nigeria is not functional, and providers in them are hardly able to identify or treat mental health conditions, even though we do have experience and research evidence to support it, that these frontline providers can in fact be trained to deliver effective and quality care for most common mental health conditions. Pervasive stigma runs across the community, and unfortunately also is rife among the health care providers, the doctors and health workers in various levels. Of course, policymakers are also very much affected by this really high level of stigmatizing attitude to mental health care. And so discrimination is common, and this, of course, results in neglect of mental health issues at all levels of healthcare in the country. All of this translates to a huge treatment gap. Almost 80% of persons suffering from various mental health conditions in the country do not receive any care in any 12-month period. Among those who do, only about 10% of them receive what might be described as minimally adequate treatment, which means appropriate treatment for the condition they have. So you're not giving analgesics for depression or vitamins for depression. Even those who do get treatment don't get it in good time. There's a really long period before they access care. All of this is happening in the context of a global move to ensure that governments provide better care for their populations. This mental health action plan by the WHO lists out 4 objectives that if implemented, will help countries to improve their health service, the mental health service, and get care to those who need the care. In fact, the WHO has devised this pyramid, and I think Nick had mentioned something about that in her presentation, about which she was talking about the inverted pyramid. Here, it's about the provision of care, which of course is that task shifting should form the tenet of expanding care and delivering universal health care, especially for persons with mental health conditions, in fact, for all conditions, with primary care at close to the base of that pyramid. And this requires well-trained primary health care providers. And as I've mentioned, we have experience that these people can be trained to deliver service. In fact, the WHO also provided.
So Oye, I need you to finish in a minute, please.
Yeah, that's right. They provided a tool for countries to be able to achieve this. And we have also demonstrated in the country that this can be used. In fact, Nigeria was one of the first countries to demonstrate the utility of this. Again, this was adopted by the National Health Council in 2013. Again, it has not been any implementation of this. This is in spite of the fact that we have evidence that we can do all of this. There's very strong evidence, randomized control trials for various conditions about low-cost treatment, and that these treatments are actually quite cost-effective. We have research evidence to show that we can scale up the packages of care at a very cost-effective level. So the promise of UHC, which is to leave no one behind, is only likely to be achieved in Nigeria if we have increased policy attention, implement existing policy, pass legislation to protect the right of people with mental health conditions, make adequate financial provision for care, and train primary care providers to be able to deliver the service. We cannot rely on specialists, and we don't in fact need to do that. But also we need to include mental health indicators in our health information system so that we can track changes and improvement in the service. Thank you very much.
Thank you very much, Oye. We will move straight on. So again, questions please in the chat or the Q&A function. We're going to move on to Dr. Modupe Oludipe, who's the lead for Health Strategy Delivery Foundation based in Lagos. And she's going to talk to us about improving access to quality healthcare through private provider networks, which is obviously highly relevant to Nigeria and other settings. Over. So off you go, please, Dr. Oludipe.
Good morning, everyone. Can you hear me?
Yes.
Okay, and you can see my slides?
Yes, we can. Thank you.
Okay, thank you very much. So Dr. Modupe Oludipe, and I'll be sharing some learnings from work done by the Health Strategy and Delivery Foundation to improve access to quality healthcare through private sector networks. The Health Strategy and Delivery Foundation, that's HSDF, is a not-for-profit organization incorporated in 2013 with a mission to improve the quality of decision-making and execution in the health sector. We do this through substantive engagement with our stakeholders by providing analytical support and driving innovation. We work with all tiers of government, that's federal, state, and local, as well as healthcare leadership and frontline service providers. We do this to improve the effectiveness of health service delivery, to strengthen the performance of the health system, and to ensure a focus on results and outcomes. Within Nigeria, we work across different states that represent the nation's different health market archetypes. So in 2013, we conducted a national level health system assessment. And the results highlighted barriers to the sustained achievement of desired health outcomes. Demand and supply side barriers, inadequate strategic frameworks to operationalize relevant policies like we've heard, that is if the policies existed, and then limited engagement of the country's private sector that has also been pointed out, These were some of the drivers for the consistent dismal health outcomes reported despite efforts by government and other stakeholders. And we have talked about Nigeria being a mixed health system, with health funding by the private sector up to 77%. And we're saying that for that to be managed for UHC goals, the private sector must be engaged. The private sector contributes 38% of health facility ownership nationally, and higher in some states such as Lagos, where private sector ownership is 89%. The private sector employs 45% of the health workforce nationally, and about 63% in Lagos State. They also provide as much as 60% of health services in many states across the country. In addition to the aforementioned contributions, the private sector is also well positioned to offer quality products and services, to scale up innovations such as digital solutions that can facilitate the UHC goals, to scale up innovative business models that can do same, to incorporate UHC principles in core business models and objectives, to contribute to financing efforts to achieve UHC, to build capacity for relevant policy dialogues and partnerships with stakeholders, including government. And of course, apart from employing, the private sector can also build the capacity of the health workforce. So the HSDF 2013 diagnostic that I mentioned, identified pivotal issues plaguing the private sector that needed to be addressed for an effective engagement. I would like to, point out that there were other issues, but these particular engagements and these particular issues that I'm going to be calling out were highlighted as foundational for our engagement objectives. And these issues are poor and variable quality of care driven by known supply side factors, low engagement in public health priorities evidenced by limited visibility of the private sector on the national database, that's the NHIS2, and fragmentation. And what do I mean by this? That's hundreds of small and independent sole proprietorships that experience barriers to growth and expansion, such as lack of access to capital. So HSDF put together a program to engage the private sector for public health goals, specifically the goal of quality, essential, health services for all, which is one of the UHC goals. We set out to implement a program and take learnings, to improve further and future engagements. We didn't set out to conduct an experimental research. And to address the issues of quality and data, we deployed specific interventions to standardize and improve the quality of care being given at the facilities, as well as interventions to enhance data reporting. To foster sustainability, and this is one of the key things, when implementing partners' work, you must make sure that there is a system for sustainability. To foster that after the program ends, we also developed and deployed interventions to strengthen the financial management systems in these facilities. And then to address the issue of fragmentation and operational inefficiencies, we deployed the network model. And because of the way, the private sector is organized or not organized, as you can see, with hundreds of small and independent sole proprietorships, it is quite difficult to engage at scale in that format. So we designed and deployed the private sector networks, which are geography-based networks. That is, facilities are aggregated according to their locations. And these networks are not social networks, but learning and improvement collaboratives that facilitate information sharing, peer-to-peer learning, and collaboration. The network model also enables at-scale interactions and supports synergies. So our theory of change was based on the premise, that facility level interventions that improve quality, enhance data reporting systems, and strengthen financial management systems. When these are coupled with network level engagements, they would result in networks of sustainable healthcare businesses that drive the UHC goal of quality essential health services for all. And so we armed ourselves with the Lagos State Local Council Development Authority map. So that's the LCDA map. We initiated conversations with the Association of General and Private Medical Practitioners of Nigeria, that's the AGPMPN. We identified LCDAs we could work in, we got letters of introduction from the AGPMPM, and we approached the facility owners. It was important to us, that the facilities we're willing to work with, or engage, had a current practice license from the state regulatory agency, that's HEFAMA. Our first engagement was in April 2014, and the second was in November 2018. We deployed the interventions, as earlier stated, at both facility and network levels, and for each strategic intervention, we conducted a baseline to know each facility starting point, to identify gaps that informed our specific interventions, and to also address, variability objectively at the network level. We also conducted post-intervention assessments to ascertain the level of improvement, or otherwise. And for both sets of facilities engaged, like I said, in 2014 and in 2018, individual facility and network level scores post-intervention improved across all intervention areas, namely quality of care, quality of data reported onto the DHIS2, and financial management systems. One of the key activities under improving quality of care was to work with the facilities to improve their adherence to national guidelines for 3 of the commonest conditions for hospital utilization. And even though network level scores had not hit the expected national guideline targets, there were significant improvements in adherence to protocol. And similarly, for both sets of facilities engaged, the private provider networks were established. In conclusion, without a doubt, for our nation to achieve universal health coverage and to leave no one behind in the attainment of this quest, the private sector must be engaged and engaged effectively. And through a number of programs, HSDF has engaged the private sector to facilitate the laudable goal of quality essential healthcare for all. Our work with the private sector has shown us that the private providers are willing to improve their quality of care and data quality if equipped with appropriate information, skills, and support. And this is an area where state governments, can look into. State facility regulatory agencies, we believe they should develop and deploy a robust framework to strengthen clinical governance at the facility. And we've been talking about, a non-existent framework since yesterday, and we're saying this needs to be in place. They should also provide supportive supervision during periodic monitoring and evaluation visits to the facilities. Our work has also shown that private providers are open to engagement and collaboration through effective structures like the network model. Like I had mentioned earlier on, this, our model, it's a geography-based provider network model that we rolled out, and it infuses features of a learning and improvement collaborative. And this model can be further explored as an enabler in engaging the private sector to achieve universal health coverage and other public health goals. So we're saying government and UHC stakeholders should conduct cost-benefit analysis to inform the possibility of adopting provider networks as a viable engagement model, for the attainment of public health goals, including UHC. Thirdly, the private providers were willing to adapt and apply innovative solutions that would foster the delivery of UHC. Please don't forget, like I had mentioned earlier on, these private providers are small, single doctor-led sole proprietorships. but they were willing to deploy technological solutions such as electronic medical record systems and drug inventory management systems, to foster the delivery of quality essential health services for all. Government and UHC stakeholders can develop a framework to sensitize and inform solution providers on the opportunities for at-scale interactions, in the private sector, supported, for example, by tax reductions and financing options. Cost savings can be passed on to the care providers, who can in turn pass this on to the care users, thereby forging a win-win situations for the care providers, the solution providers, government, and the care users. Thank you.
Thank you very much, Dr. Oladipe. We will have to move straight on. So our final presenter is Njide Ndili, and she's country director of the Farm Access Foundation, which I know operates in many countries. And she's also going to talk to us about the role of the private sector in accelerating UHC. And I welcome you to give your presentation, Dr. Njide. We can see your slides.
Thank you so much. I was trying to unmute myself. So good morning. And again, it's fantastic to speak to the audience. I'm leaving my video off so you can hear me properly. I'm having a bit of network issues today. I think the beauty of speaking last is that quite a number of things have been said, a number of issues, similar issues have been. I'll come at it from practical examples of what we've done, integrating private sector into the vision of UHC and accelerating UHC. So I'll start with just showing the fundamentals of how we operate as Farm Access. We try to identify the key pillars towards successful UHC achievement or accelerating UHC. One is the demand side, supply side, the governance structures, and of course the responsibility of the patient, and how we can also try to change behavioral or health-seeking behavior. But fundamental to all of this is the issue of trust, the fact that trust is still very low, and there has to be a way to improve the trust in the system. If a patient is going to prepay for healthcare, they have to have the confidence that when they actually seek the care, that they're going to get good quality care in the system. Of course, the governance structure being available and the people having the capacity within those institutions to properly monitor and track what is happening within the system. So this is a framework through which we operate. And what is unique approach is that we actually intervene at different stages throughout all the pillars. So we have interventions in the demand side, governance, supply, and the patient behavioral change activities. So some of this, the UHC position of Nigeria has been talked about, so I'm not going to go in depth into this, but it's important to kind of stratify the different areas. The fact that you have, operational challenges, you have policy challenges, and then the environmental challenges, also including the economics within the country, the poverty rate, and so on. So it's very key to have this in the back of the mind while we try to tackle what the barriers are with UHC. Now, the private sector plays a very critical role, whether we would like to acknowledge it or not. Over 70% based on the data that we've collected of care is provided in private sector. Of course, the patient-doctor ratio is, significantly below what it should be. And who is filling that gap? So in some of the discussions yesterday, there was mention of community pharmacies and patent medicine vendors, even being the front line in terms of providing care. Again, this is private sector, and we need to look at how they are properly, oversight, regulated, and integrated, or even their roles recognized in terms of delivery. Government has quite a number of primary healthcare centers, but because of our, the information that we have so far, quite a number of them are non-functional. So what can be done to increase the functionality of some of these UHCs? And of course, we've talked a lot about the high out-of-pocket payment for Nigerians seeking care. So having this at the back of our mind, how do we then bring in private sector to work in a kind of collaboration or PPP with government? It's important to emphasize that government always has to take leadership, which is why the political will is forefront, but there are significant roles that can be played by each. For government, they have the policy, they actually have the patience, because as we know, a lot of states in Nigeria, 30 as at the last count, if not more by now, have mandatory health insurance laws trying to accelerate UHC. So in a sense, it's the state governments that really should enforce or motivate the citizens to tap into the UHC laws or infrastructure that has been put in place. Again, the government has the structures and infrastructure around the primary healthcare centers, which is key to UHC. So in a sense, how can you bring in private sector? And on this slide, you can see how we try to delineate the roles each side can play. Private sector can, of course, bring in their efficiency and their funding as well as quality, but working in partnership with government to make that happen. Now, if I go to this next slide, which I showed before, I just wanted to show how Farm Access is really intervening. So try to work with government to implement their health insurance programs, and I'll talk a bit more about that. On research and advocacy, we try to showcase what we've done through impact evaluations, just to show what works and what doesn't work. On the patient side, the promotion of technology, including mobile technology, to enable access. Then on the supply side, we are promoting loans, access to finance for healthcare facilities so that they can improve their quality. Even in PPPs, we are putting in a lot of money there. Quality standards through our safe care methodology, and in some instances, equity within the supply. We have to improve the supply side for demand side to have trust in the healthcare quality coming out of it. So running very quickly into specific examples, what we do with state governments. Of course, a lot of states are at different stages of implementation of their laws, their mandatory health insurance laws. These are just to give some examples of the processes that we have identified that are critical to successful implementation. And I won't go through all of this, but again, these are some of the involvement that we have through partnerships with the state governments to make this, to be able to implement the mandatory health insurance programs. Now, I wanted to highlight this because it has been discussed for many, many years. The Kwara State Health Insurance, Community Health Insurance Program, which started as a PPP in 2007. At the time that we started this program, there were a lot of skeptics and a lot of push. But again, to emphasize that it was a pilot, and it was from the learnings from this scheme that really catalyzed the need for insurance being mandatory so that you have risk pools, the involvement of government, and the fact that government has a role to play by, taking care of or designating a percentage of their consolidated revenue to pay for the indigents or those who can't pay, and the need to bring in private sector providers. So this is just to give you a snapshot, and all the details are in there of what was accomplished. At some point, it was the largest PPP community health insurance scheme in sub-Saharan Africa. But at the time, Farm Access was in the lead. So we had to reverse the structure so that the state government takes ownership. And I'm happy to say that after so many years of stopping, we stopped the program in 2016. Tomorrow, the scheme is going to be relaunched by the government. And it's important to note this transition, that the government now took the leadership. The reason why it took so long for it to be restarted was that we decided to take a backseat. That we transferred all the learnings to the government, even though we were still supporting from the back, but this is your program. It is your budget. We can support with structures and best practices, but it is your program to run and you have to take ownership. So the scheme, a big congratulations. Even the fact that it transitioned governments, opposing parties, it will be relaunched again tomorrow by the new administration. So I think that is a key learning, political will and what can be achieved through UHC. Then the role of technology, also very important to note that whether we like it or not, that technology has a role to play. especially with aggregation of funds, okay? Combining financial flows, even provide an individual empowerment, lowering transaction costs. Without technology, it is almost impossible to achieve UHC. So I think that this needs to be at the back of all the scheme designs, and all the different benefits needs to be factored in for UHC to be accomplished. I really needed to highlight this. Then just quickly, I'm just going to flash through some of the interventions that we've done. On the supply side, again, talking about our interventions, we try to not only implement some pilots to prove a hypothesis, but we actually embed ourselves within the governance structures or the regulatory framework to build capacity. Okay, so this is an example of how we've structured ourselves. We are providing technical assistance to federal and tertiary institutions such as FMC Ebutemeta, which has been in the news lately, Federal Ministry of Health, Pharmacy Council of Nigeria, and so on and so forth. So again, it's important that even as we're implementing at the state levels, we need to find a way to build capacity with the regulator. This is just to show some of the different areas covered by the standards, just to help improve quality on the supply side. This is just a bit more detail about what we're doing with the HEPFAMA, which is the regulatory body in Lagos, Pharmacy Council of Nigeria in terms of capacity building, helping develop standards and so on. Now, using Lagos as a case study, we're really embedded in Lagos, both on the supply side, demand side, helping to even paying for some indigents just to test the system to make sure that it works. And you can see the details of what is going on right now. And I can say that as of today, there's over 200,000 civil servants. The governor has paid for the premiums of the civil servants, and there's a bit of momentum in the system in terms of traction towards UHC. On the supply side, we also try to put our money where our mouth is to help catalyze investment in the healthcare sector, because I think on the supply side, because I think that in order for you to improve quality, there has to be some kind of access to finance. And we know that, you know, with the fragmentation in the system, the sole proprietorship of the healthcare SMEs, it's almost impossible for them to get loans to improve either scale or scope of their facilities. Now, yesterday I talked a bit about what is happening in Delta State. This is a picture just to highlight.
Dr. Njide, if you can wind up in a minute, please.
Yes, yes. So to show that a public PHC can be run by private sector and get it functional. So this is another example, you know, I wanted to show. Then, you know, there's also involvement in the tertiary facilities, because again, a lot of patients are going to the tertiary because the primary is not that functional. How can we, you know, improve the system throughout? Then rushing through, also capacity building, the fact that we've embedded healthcare training within the Lagos Business School, just to build capacity, because it's key for healthcare practitioners to understand how to run a healthcare business. Then my final slide is just to show that you can actually divert or integrate vertical programs into supporting a state's journey towards UHC. So we're involved in so many different projects, but in all those states, we try to channel the funds towards the central achievement of UHC. So this is just a mind map of some of the activities that we're doing. So in a nutshell, all this has been talked about, the importance of private sector, the mapping, roles and responsibilities, the use of technology, and I'll end with that. Thank you very much.
Thank you very much, Dr. Njide.
Back to you.
That's the close of the presentations. We've been allowed a small extension in time. So we've got maybe a little bit over 10 minutes for questions. So if people do have questions, can they please raise their hand and you'll be identified by one of the facilitators. And we've got a couple of questions in the chat. So I might, if I call your name, I hope somebody can unmute you, and then maybe you can give your question verbally and one of the presenters can respond. So the first, I know there's been a response in the chat, but from Obioma, there was an interesting question to Robert, our first presenter. But Obioma, I don't know whether you want to ask your question in person to get Robert to respond. Over.
Yeah, thank you very much, Mike. I was trying to express my appreciation to the presentation by Robert when I highlighted the comment he made about the inefficiency of community-based health insurance schemes. I was thinking that in its place, does he think that a mix of fair tax-based financing strategies can work better? And I was thinking that options like earmarking telephone and SIG taxes could actually be a saving grace, realizing that the poverty rate in the country is very, very high, and getting premium from such unstructured tax administration group can be very, very difficult. So I was thinking that an alternative approach can be picked from a key recommendation of participants of Senior Executive Course 41 of NIPS, National Institute for Policy and Strategic Studies in 2019. One of the key recommendations they made was if Nigeria can create a law that allows 1 kobo per minute of call from Nigerians, we will raise substantial revenue to the tune of about 216 billion naira from 100 million active lines. If this money can be picked together and earmarked for health financing or for health care, in addition to seeing taxes like alcohol and tobacco, so much can accrue in the basic healthcare provision fund, which was created for that kind of purpose. I think it will work. And I think from his answer is a way to go. And we have to explore this through further research. Thank you.
Great, thank you. Robert, if you can keep your answer short, that'd be great.
Sure, absolutely. And to keep the first part very short, yes, community-based, voluntary community-based health insurance, unfortunately, doesn't work. I mean, there have been decades of experiments with this, but it tends to have very low coverage, doesn't cover the massive people in the informal sector. And, you know, that we need to move on from this, and that public financing is the only way. And there you are looking at a mixture of tax financing mechanisms, looking at the structure of the economy with that enormous informal sector in Nigeria. Payroll taxes are not likely to be massive for the time being. So looking at progressive ways that you can tax both wealth and the wealthy and their incomes through things like you're mentioning are excellent ideas. But I come back to what I said yesterday. Don't forget, you know, perhaps the greatest resource is the oil revenues in Nigeria. You know, you have natural resources, which, you know, if you renegotiate your contracts with the likes of Shell and people like that, and they pay sensible amounts of taxation, is likely to be much, much better and effective at covering the entire population. So I would go for natural resources more than anything.
Thanks very much, Robert. There were a couple of questions which I think are linked from Dr. Babalola in the Q&A. So Dr. Babalola, if you want to ask those questions, I think you had 2 targets for them. Over.
Hello? Hello, yeah. Good morning. Okay. Yeah, good morning. Thank you so much for the presentations. Coming from the point of view of pharmacists, I'm interested in the role of access to quality medicines in achieving the UHC coverage, the UHC in Nigeria. We do suffer from a lot of poor supply chain. And I always wonder if we can achieve UHC without quality medicines. And to Dr. Njide that just spoke, I was interested in the farmer access and their roles. And I'm asking whether she mentioned the patent medicine dealers, they should be trained and all of that. I do know that in Australia, the government empowered pharmacies to be spread to rural places. And another country too that I've read, if they are giving some incentives, we can have skilled professionals providing quality medicines in rural places. I wonder whether these are the areas we can look into as we're looking at UHC and primary healthcare. Thank you.
So thank you for that question. Let me answer really quickly based on the work that we're doing with Pharmacy Council of Nigeria. Currently, there is a project called Integrate E, which is funded by MSD for Mothers and Bill and Melinda Gates Foundation. But basically, it is to find a way to have the Pharmacy Council of Nigeria regulate the activities of the patent medicine vendors in a structured manner. Some of you may know that there's a huge gap with availability of community pharmacists and patent medicine vendors, such that there's a proliferation of patent medicine vendors, especially in the rural areas when they can't access healthcare, proper healthcare facilities or licensed community pharmacies. So what is happening is that we are trying to develop a framework in partnership with the Pharmacy Council of Nigeria, where there's an hub and spoke model with community pharmacies overseeing the activities of some of these patent medicine vendors, such that the supply chain is guaranteed. There's training provided to the patent medicine vendors, but again, under the supervision of community pharmacies and the regulator, the Pharmacy Council of Nigeria. We feel that no matter the care that you're providing, if the quality medicines are not available, then there's a break in the system. So we have to look at it from an end-to-end perspective. So yes, there is a huge role for pharmacists and patent medicine vendors in achieving UHC.
And I'd quickly like to add to that, Mike, if that is fine.
Yes, please do.
Okay, yeah, definitely there is a role for strong supply chain systems, for us to achieve quality. We can't talk about quality healthcare, without the supply chain being strengthened. And even in the work we did, you would have heard me mention the drug inventory, the management system. So we ensured that our facilities came together and even did the pooled procurement, of drugs, one of the cost-saving mechanisms that we had. So just to quickly ride on that, what Njide also said, just to back that up, that we cannot, be talking about quality, essential healthcare for all without, strong supply chain systems being put in place. And this is end to end, from the manufacturers to the users. So it's the whole length of it, that we need to strengthen. It's a whole lot, but just to add to the conversation, that it needs also to be in place and strengthened. Thank you.
Thank you very much. There's a question from Dan Onyeje.
Good morning, all. Thank you so very much to all the presenters. I learned a great deal from all the high quality presentation made this morning. Thank you very much for that. I want to learn more, particularly from Robert Yates. He keep on mentioning that South Africa is not a good model to follow. But I do know this. Long before the COVID pandemic, South Africa had the lowest out-of-pocket expenditure per capita in Africa. And they made a conscious political decision to move to a one-payer system last year. In fact, a good friend of mine, Nicholas Crisp, was appointed head of the National Health Insurance Fund. And the South African government made a commitment to be paying or expending at least over $2 billion US dollars per annum to cater for the poor in the new system. So as a developmental process, I would say that South Africa actually did quite well. So why is it a pariah, as it were, a developmental model for others to follow? Can you please elaborate? Thank you.
Yeah, very good question, Dan. And I know Nicholas very well. And I think it is a great model, the NHI model in South Africa. The problem is they haven't implemented it yet. You know, the previous system, or the current system that hasn't really changed, is phenomenally inequitable. You have about half the health expenditure going on about 16% of the population who are in private, very inefficient health insurance schemes. The other half of the population, sorry, 84% of the population are having to sort of cope with very underfunded public services. So the attempt by the NHI is to bring these two together into a national system. It's been piloted for about the last 12, 15 years, but hasn't really taken off yet. But there is very high expectations and hopes that coming out of this crisis, that the government is going to fast track this. So I would say that the NHI model is excellent. The problem is it hasn't been implemented yet, but watch this space, because I think with, particularly with President Ramaphosa taking charge of it now, he's brought it all into his office, into a war room. There is this potential for this to happen. So very much look out for what happens in South Africa.
Great, thank you very much, Robert. And we've just got a minute or so left, and I'd like to give the final words to Dr. Necker as a representative of the Federal Ministry of Health. So over to you, Dr. Necker.
Right, thank you very much. So I was just going to chip in a few insights concerning what Dr. Obioma had suggested about the telecom tax. So just to share a bit of experience. So it's a very good model, wonderful model, but just to share some experience. When the National Health Act came into being, so we went ahead to do a bit of work on looking at aviation tax, telecom tax, and all of that. I don't have the numbers, you know, clearly now, but we were able to churn out, you know, great numbers, which looked very interesting and very promising. But we also looked at other health systems issues. That was why during my presentation, I made mention of the fact that, look, UHC's strategies should be country tailored. What works for you in your country? That's the strategies that you should adopt to move forward. So we looked at the taxing system, how it is operated within our Nigerian system. So somebody makes laws on the taxes, somebody does the remittance, somebody does the collection. All of this has nothing to do with the health system or the leadership of the health system. And then somebody decides from the entire collection, what goes to health, what goes to education. So remember, the fact that you are advancing that cause, asking for that, does not mean that you're going to get a fair share of the total outcome of the telecom tax. There are other competing needs. And that's why I mentioned the fact that it's an opportunity for us to look at a multi-sectoral approach such that we don't continue competing where there isn't any need for competition. So just to say that, yes, telecom tax, awesome, but we need to be careful while we look at other health systems issue that may not make it very workable for us within the health system. Thank you.
Great, thank you very much. And I think we will have to close it there. I'm sure we could have had much more discussion for some great presentations, and I'd like to thank all the presenters for really giving us a great deal of insight from their personal and professional perspectives. We are going to go straight on now to the breakout group sessions. So I'll be handing over the chair now to Friday. But thanks again, everybody, for your questions and engagement. Over to you, Friday.
Thank you, Mike, for that great session. Is everybody hearing me? Yeah, good morning, ladies and gentlemen. And it's my pleasure to now lead you to the breakout groups reporting back. And you also know, yesterday we had 3 groups that met in parallel sessions. And today, over the next couple of minutes, we'll be asking the groups to report back to us in plenary. And then we'll have about another 10 minutes to discuss the recommendations they've made. We have 3 groups. One is the policy group, another is the research group, and then the third one is the multi-sectoral group. It's now my honor and privilege to invite Dr. Chima Onoka to present for over 10 minutes about what the policy group decided yesterday. So, Dr. Chima, please, take your presentation. 10 minutes, please.
Thank you very much. I'll be sharing my screen. Okay, can my screen be seen?
Yes, visible.
Okay, thank you. So we had very robust discussions, and it was a very good participation. Well, you know, many stakeholders were there. We focused on the policy aspects of our discussion over these 2 days on understanding the context of coverage and the progress. So we try to tease out a number of things, of course, whether there's a vision and that vision where it is, and then the strategies that are encapsulated in it, and as well as, you know, going further to look at the barriers and challenges. And then we try to bring out points around points for action. So first of all, you know, starting with that vision, participants felt strongly that a policy direction exists, and this is reflected in the National Strategic Health Development Plan, the National Health Policy, and the Act. But there are huge challenges with awareness, and there isn't a clear system of accountability that is effective, and that implementation is weak. I'll speak a bit more about that in the subsequent slides. And the strategies that have been, you know, that need to be brought forward to, you know, to move things forward, you know, include having stronger stakeholder engagement, clearly defining who the stakeholders are, bringing them on board to the conversations, and that the vision actually really needs to be shared with all stakeholders. Issues around accountability for those at the political level. Clearly, electability in Nigeria to positions of authority, especially at the state level, isn't connected to issues like universal health coverage. But this can be strengthened if, you know, there are things like competition. You have things like competition at the subnational levels amongst governors. Whatever could be, will be, you know, can be done to stimulate competition at that level will be useful in stirring up political will at that level, and of course at the national level, and also at the local government level. A clear communication strategy. So there are lots of things that are on ground, but they need a clear communication plan. They need to be packaged first of all, and then there's a clear communication plan through which that information, the information around UHC, can get to the leaders and the led to enable them to take the right action. And there's a need for UHC policy champions, people who are influential being drafted, you know, to the discourse, and then they can drive a lot of the advocacy that is needed, because that advocacy is needed at the top level in the government houses. And of course, that the focus should be on trying to think about what the minimum standards are at the national level, but the specifics will really be tailored to the states. And then these things can be tracked, adapted, and implemented And the incentives to motivate right action can also be clear at those levels. Current efforts and the successes and learnings from it, I think a number of them have also come out, from some of the speakers. There are quite a lot of UHC related initiatives that have happened related. I mean, even if they are not connected to an overall plan. But it's been clear that success has been linked to political leadership. Where a political leader is interested, success is possible. When they are not interested, it is difficult. Technocrats, bureaucrats will just be reviewing policies and writing new ones and editing and turning the papers until there is a political window. And this is in line with evidence that is also out there. When political windows of, meet ready, meet technical guidance that has been packaged, those opportunities lead to real quick differences. So stakeholder engagement, citizen education is poor. It's still not something that the citizens in Nigeria are actually aware of and ready to even support or to help drive. Alignment is needed. And so discussions like what we are having, this kind of meetings, there are lots of stakeholders who actually drive a lot of process that we will take steps to start engaging more deliberately. The NSSGP has been developed, but like has been said, even commissioners and even people at the national level still don't even know the content. And we are already like 2 years plus into its implementation. And it will be over in the time for it to pass in another 2 years. And then the issue of partners have been spoken about. The Basic Healthcare Provision Fund, of course, has been talked about as well. It is very small compared to the need. And so there is that risk of fund displacement even before its implementation hasn't really started. There is already a risk of fund displacement at the state levels. People saying, governors and decision makers saying, Basic Healthcare Provision Fund money is already coming. Why are you asking for this kind of budgets for health again at the state level? The National Health Insurance Scheme, we've talked about it, not being mandatory, but there are concerns with even saying that it needs to be compulsory, but those decisions have to be made. Then, it also needs to be more comprehensive. All the evidence that is available points to the fact that it's actually somewhere around 2-point-something% of Nigerians that are covered. There is yet no evidence that suggests that it's up to 5%. We hope that something like that can come out. It's still somewhere around 2.5%, and until some real information comes out. There are issues with accountability and that hinders engagement with that level, with that platform. Political leadership needs to understand the subject matter. So there's a lot of work to be done to redirect and refocus leaders, and for them to also see that there are clear timelines and it's a stepwise process, not that people wake up and they want to achieve everything during their tenure. And because of it, it turns them towards vertical programs. They need to agree that others can continue from where they stopped. And then the agenda needs to be connected to accountability, like we've said, and have real political leadership, not just technocrats designing the policies without an interest from political leaders. And then at the end of the day, that's never implemented. Private sector contribution has been raised, and I won't say more about that. So the barriers and challenges that have been out there, critically, the poor appetite for system building is very critical. It's a key issue that came out of that conversation. There's a poor appetite for that amongst those leading at all levels, not just political leaders, but even at the ministries and all that, for system building. And so that leaves a lot of vertical programs, which, because people want to achieve them during their own tenure, which may be 2 years, 4 years, it makes them to rest on those vertical programs. Fragmented approach to coordination, which needs to change, and also the issues of financing, which has been raised as well. And then that the organizations within the health sector and outside it haven't yet been oriented towards a UHC agenda, and the changes that need to happen in those organizations haven't started. So are there mechanisms that we've identified? Yes. I think I've spoken about a number of them already, bringing up clarity to the discussion at this level, UHC being embedded, in every sense of the word, and then engaging the private sector, then policies, pushing for implementation of the policies that are in the NSSGP already, and financing through more innovative mechanisms, and contextualizing the models of UHC. And then that it's not just about financing, but there are things that involve the communities and involve, individuals, groups that Nigerians use as social systems as well. And then regulators and all that need to be separated from the providers, and to take advantage of, the polio, the COVID-19 pandemic opportunity towards building a resilient system. Key priorities for going forward, and that's to bring this to a wrap. The health system, we need to focus on that, building that up, and then learn from other countries that are trying to take advantage of the COVID opportunity, what they are doing, and that can help us move forward. Address other areas like hunger, poverty, alongside, and then raise awareness up to what we call in Nigeria the grassroots, until it becomes a grassroots movement. And there are lots of discussions about strategic purchasing to improve the efficiency of and effectiveness of funds that are being pushed down the line, to even increase the trust in the system that will allow, more funding to go into health. And of course, to improve the political and, technical interface, and strengthen the practices around procurement, and supply chain issues have also been raised during this discussion this morning, and to also be sure who the stakeholders are and to engage them deliberately. I think finally we have a list of various stakeholders from the conversation that happened yesterday for further engagement, and I think that's where we got to. And thank you very much. I think the comments can follow for additions and whatever I may have missed. Thank you. Back to you.
Thank you. Thank you, Dr. Noka, for keeping your time. And we will keep the questions and comments to the 3 presentations that will be completed. So it's now my pleasure to invite Dr. Taya Merchant to present the findings from the research group. Dr. Taya, please.
Thank you so much, Friday. Can you see my screen and can you hear my voice?
Yes.
Perfect. Thank you so much. And so following on from Chima's presentation, here I'm representing the group that met yesterday to talk about research priorities in advancing the UHC agenda for Nigeria. And I want to thank the group very much for a very constructive and interesting conversation. And I hope that you're going to find that some of the issues that we highlighted overlap with those from the policy group, but we have a very specific lens that we've applied, given that we were targeting this from the perspective of researchers. Similar to Chima, I'm going to follow a structure whereby I'll have 3 slides highlighting 3 priority strategies that we identified, 1 slide on a set of barriers that we thought were preventing us from doing our best work, and then 2 slides highlighting priorities going forwards. So before we even get started on the first of the 3 strategies, just to underline something that was really universal between us, and I think for all of us as a group, which is that whatever the vision of UHC is for Nigeria, we must systematically prioritize equity and high quality care. So whatever the package of care that's included in universal health coverage, so the National Strategic Plan 2 has laid out what the components of UHC look like for Nigeria. They have to be delivered equitably, and they have to be delivered at the highest possible quality if we are to achieve health gain, which is, I mean, the thing that Nigeria is perfectly poised to do. So we thought of 3 strategies that will help to operationalize this. And the first of these is a common theme: political leadership and governance, that UHC really still needs to become prioritized in the political agenda. A very core theme for us, it ran through all of our discussions, was the need to consider actions and solutions at both national and state levels. So we placed quite a high premium on the need to take account of the very varied context between states, and that when federal level makes recommendations and has strategic goals and policies, actually the majority of the work takes place by the group of actors who are in states, who have their own leaderships and their own competing demands and priorities. So all of our strategies need to take special attention, pay special attention on both a national and a state level response. And we thought that at the national level, of course, there's a role for accountability, and there's some research perspective, there's some promise in the strategy of benchmarking between states. It's certainly been something that's been shown to be quite effective in the role of immunization. It's being used increasingly in maternally born and child health care, and I'm sure across other domains of healthcare delivery. But that there needs to be a drive towards accountability within states for their individual implementation and performance. One of the things that we think limits this strategy that we would want to promote as a strategy is to promote the importance of health as a concept. So when talking about economic development of the country as a whole, we feel that there is still a need to promote health as a top priority for the country, and that there's an interesting and important conversation to be had about the strategies that would help to drive that. It should include mobilizing communities, using community voice more effectively to exert political pressure. And of course, we'll need to make use of champions to help drive messages through. So political leadership and governance is our first overarching strategy. And our second one is really focusing in on the primary healthcare system as the bedrock of UHC. Of course, the different elements of health that are being delivered through UHC might include and have to include secondary and tertiary healthcare. But if we can't get the primary health system right, including engaging the community right from the bottom up, then we feel like we are struggling to even really get out of the go blocks with UHC. So we would like to see a revisitation of the structures and the systems for healthcare delivery at the state level in primary healthcare. What is working? How is it working? Why is it working? Where the primary healthcare system is not working, why is that? What do we understand? So a theme also that arose for us from a research perspective is, can we move from describing the many problems that we know to exist and start to focus our agenda much more around strategizing around solutions? Reflecting on the issue of quality, I think it's really crucial that we're very thoughtful about what's the quality that PHCs can provide. So primary healthcare is delivering promotive and preventive and curative health care, and all of those dimensions have quality issues around them. So what is it that PHCs are doing well? Where are they providing good quality care? What needs to be improved? Where are the gaps? Inevitably, there was a large discussion around finances, it's a theme across this whole workshop, of course. So when it comes to conceiving of PHCs as the bedrock, are we sure that we have the right funding flows? Do we have the right investment in the right areas? Do we have an appropriate accountability system for the allocation of funds? And sometimes it's not only allocation, but actually release of funds. Do we have the accountability for release of funds within states? We've touched on the National Health Insurance Scheme, and we talked about that too. We talked about the need for research that would help to strengthen that exists, but clearly there's a need for research that helps to develop mechanisms for financial risk protection for people outside of that scheme, for the poorest in the rural areas. And then research that would help potentially with prioritization. So there was discussion yesterday in the plenary about incremental steps to UHC, and in our group we talked about progressive UHC. So where there's some prioritization in a stepwise process whereby we want to achieve given levels of population coverage across the gamut of services being provided through UHC. And maybe we can't do that all at the same time as having our eye on full service coverage and financial protection, but we need to have a roadmap to make sure all three are being tackled. And then finally, our third priority strategy is around community involvement. And this links again to this concept of governance, accountability, and also to promoting the primary healthcare model. We feel that, populations vote with their feet. Demand is insufficient in Nigeria. And part of that is because people know that the quality of care is not always available to them. But also people do not always know what their rights are to healthcare. They don't have adequate information about the type of care that they should be receiving. And we feel that there's an opportunity for research to contribute by representing and highlighting community voices and integrating that then into policy dialogue. And so our research responses need to be fit for purpose to address community needs. And crucially, our research communications need to be very thoughtful and address communities when we're discussing our findings. There's an additional point there when we think about strategies that can promote primary healthcare, which is that Nigeria now has adopted the Community Health Influencers, Promoters and Services, the CHIPS initiative. There's an obvious opportunity there to use that initiative to effectively promote the UHC in the short term, because let's face it, we do need to identify actions that we can take immediately, as well as actions that might take a little longer to instill. So thinking about barriers, why are we not currently doing the things that we wish that we would do? And we had three main areas here. The first is that we felt that research is not always designed with research uptake in mind, and that there was discussion around the research culture, which I think is true for Nigeria, it's true beyond also. So that as researchers, we must be more proactive and thoughtful about mapping and involving a broad range of stakeholders from the outset. Who is it who we want to take action from any of the research evidence that we generate? And our activities mustn't just stop at planning and involving people at the outset, but we must be thoughtful all the way through to effective communication to those different audiences at the end of research activities, making sure that we target different audiences with appropriate messages and products. The second issue was more of a domestic issue, and that's around research not always being allocated sufficient funding within Nigeria. So I think we would all agree that research is most effective when there's country ownership, but most research currently is externally driven, and that really is perceived to limit research uptake and actionability. So if there is a barrier currently that there's not enough research investment in Nigeria, I'm not entirely sure how we would address that, but it's something that we would like to see more of. And particularly because we saw a need for more effective communities of practice, more collaboration and coordination between research activities in Nigeria for more opportunity for research uptake. And then finally, there's a barrier that we identified around fragmentation of the concept of health. So I mentioned on the first slide in governance around the need to have the topic of health embedded in the discourse around economic development for the country. And some of the reasons we thought that this is challenged is because there's a multiplicity of vertical health programs in Nigeria. So we sometimes just talk about malaria, or we just talk about HIV, or we just talk about immunizations without necessarily linking it to the concept of a person's holistic health. And then, of course, there are weaknesses across the health system that just exaggerate that fragmentation. So finally, priorities for action. And I've divided these into two topics that we...
Tanya, please hand up.
Yeah, thank you. I will. So two groups here. The first is around topics for research. So research that aims to optimize the primary health system, identifying which health system building blocks need to be strengthened and how. Research that purposefully tries to understand the end users, so that's targeted on community targeted research. And then there were three areas of research that we thought were really crucial around financing. So around efficiencies in health financing, around effectiveness of resource allocation, but also around improving financial risk protection for communities. But then there were a group of research priorities that were more cross-cutting. So the first of those is around this issue of collaboration and coordination. So UHC needs a large type of data, it needs diverse methods to be applied. We can't all do everything. What can we do to help build a stronger community of practice? We must push ourselves to go beyond descriptive research and be much more thoughtful and focused on evidence-based solutions. Definitely to learn from other countries about how they've responded to COVID-19 to inform potential strategies for UHC, but not forgetting that whatever research agendas we develop going forward, they must take account of the state-driven action and the differences in context. So thank you very much to the group again, and thank you for this opportunity.
Thank you, Tanya. Great presentation. Because of time, we have to invite Professor John Idoko to present the recommendations from the multi-sectorial group. John, please. John Idoko. Ten minutes. Professor Idoko, are you there?
Are you here? Do you see my slides?
I'm seeing it now. Thank you.
Okay, great. Thank you very much. So first, to thank the members of the group for the very lively discussion yesterday. And I hope that I'm representing, of what we all came to as our final thoughts. I'm sure that I would have missed a couple of things. I guess that in the last 5 minutes that is allocated during the discussion that can come up. So in terms of the strategies, again, there's a lot of overlap, but our main focus was on multi-sectoral collaboration. Engagement of government at all levels to bring attention to the need of UHC is critical in ensuring sustainable funding and encouraging communication between the federal government and the states and non-state actors. We had over and over from various speakers about the lack of political will and the lack of political commitment. So, and the gap between the politicians and the technocrats, and also the gap that exists in terms of collaboration between government actors and non-government actors. So that's political engagement is a critical component of what we believe should be the vision for UHC. Developing a policy framework to strengthen collaboration. We heard from Dr. Oji this morning some of the power plays that happen between, the Ministry of Health and the non-health actors. And unless we're able to have a framework to be able to bring them together with a vision for UHC, we're not going to make much progress. And when you go down the line, even with the gaps that we see between the federal government, the state government, and the local government, because of the concurrent nature of our, health system, we need some frameworks there that bring people together. And we've had how difficult it is to operate at PHC because of the gap between, the supply side and the demand side. These are all issues that require a very thorough, framework to bring about the synergy that is required to see this vision. We've also had the lack of community involvement. Those are things that need to be addressed in terms of this framework. And I'm happy that we're just talking after, the research issue. Even multi-sectoral collaboration requires a lot of data to look at the various gaps, in terms of the planning, implementation, monitoring, etc. So these are all things that we need to look at in terms of strategy. Current efforts and successes and learnings. We've heard about the successes from polio, how it came about, the insights into how to address the various issues, the competition that, was engendered between the states to be able to, advance the goal of, eradicating polio in Nigeria. We believe that such can be brought to bear, not only in maternal services, but even the whole vision of the UHC. We had, in our group yesterday, how, community-based health insurance system can be very, very important in driving, services to the community, and therefore helping to improve the uptake of services. So those are some of the things that we believe are extremely important. Funding availability in the primary healthcare setting was shown to increase access to medicines. We heard that that was a major strategy that was used by the National Primary Healthcare Development Agency. We also learned about the successes from the MDG component of the NHIS, which ran and was implemented in about 14 states, but stopped as soon as the MDGs came to an end, wasn't sustained. So the question is, can we come back to use the same system to take up and focus on UHC? This is a success story and something that we can look back and learn the lessons from and take the tools now, to UHC. So this is something that our group also discussed yesterday. Next. Now, the current efforts, strategies, and learnings, the additional point that we had. You all have this morning the presentation from Njide where, there was a public-private partnership in running various, health facilities from the PHC even to tertiary institutions. So those are things and strategies that we should be thinking about, as we look forward to ensuring, that we move along the goals of UHC. And then, because this ensures that people have both insurance and access to facilities. She also talked at length about the success of the PHC services in Kwara State, which was like one of our first community-based health insurance schemes. And we believe that in that group that this is something that we need to replicate in many of the states, particularly that many states are now coming up with their, health insurance schemes. And in one example that was given, TBS has been financially incentivized 200 naira per mother to encourage maternity and postnatal care into PHC to overcome the lack of mothers using PHC facility. This is not the first time that there is such incentives, but those are things that can sort of stimulate, the uptake of services, which is a big gap as far as the PHC is concerned, given the lack of trust and confidence that communities have in all these facilities. The broad takeaway of all this is that states need to experiment UHC, but learning should be shared so that successful approaches can be replicated, as we move on. Now, what are the barriers and the challenges that were discussed? Of course, the lack of senior government engagement and the UHC champion, which has resonated in all the presentations. And lack of senior government engagement starts from the president to the governors to the chairman of the local governments. And we all know in this country that once those are not, if we can't carry those along, the programs are not going to receive government attention. They're not going to receive government funds. I think one of the things that we must go along, to convince the politicians is how important health is, and also getting, the communities to ask questions and ensure that during elections, that people are not talking about roads only and bridges, but also the human capital, the health of the human capital, and the education of the human capital. Those become very, very important things that we need to start looking at, because these are the major barriers. There's a lack of clarity as to the responsibility of the NHIS, and we're not surprised, right? After over 10 years of its inception, NHIS has now gone up to 5%. And as we all know, it's only the government of the country that is, are paying capitations on behalf of the workers. So these are things that we need to look at and see, how we can reform the NHIS and ensure that it has a strong collaboration with the states, so that state health insurance schemes can be made, to become effective and efficient, particularly that many of them had stages where they are almost taking over. The other point that was discussed was that if you look at the insurance providers, their key performance indicators focus rather on profiles than the lives of people to be saved. These are things, again, this is based because most of them, or things are looked at in the vertical form. And the question is, how do you use, like the presentation we had from today, how can you use those vertical programs to sort of leverage on, the global vision that we are seeing, or the national vision that we are seeing for UHC?
Oh, you should be rounding up now, please.
Communication.
Please, round up.
Okay. Low level of awareness about UHC in the community, and the lack of clarity of current strategies and KPIs. Next. Funding. It's an issue. NHI is not working to ensure good use of funding. We've been told about the issues of accountability and integrity. Access is variable between states. I think that we must therefore learn to be flexible in our implementation to adapt to the context. Resources is a problem. Many PHCs, are far from the communities. It takes time and money. These are some of the barriers. Next. And the feedbacks look overwhelming sometimes. Are there possible mechanisms? Yes. It's an agenda that should be on the fora for discussion by politicians, governors, the National Assembly, the National Council of Health, etc. Gathering data to highlight the gaps in delivering, the various services, encouraging all stakeholders from senior government officials right through to the communities, so that we can, sustainable fund and develop services that are right for the locality and ensure users access to them. The issue of champions has been, mentioned several times, and here, the Nigerian Academy of Science, the support from organizations like the AMS and many local foundations can help to support and bring to bear professionals, civil society, and others to jointly advocate, and to hold, a government accountable for, the universal health coverage. Next. What are our priorities? What priorities were discussed? Focus on states rather than, the center, because, we learn from the issue of polio that if we look at the states, that it's a lot easier to manage, and we know that there are different levels and they can compete. Build an alliance for private sector on UHC, leverage on the experience of polio and COVID, and then list champions, who can re-engage stakeholders at all levels they need for UHC. Coordinate activities between all stakeholders and ensure a sustainable fund. And very importantly, continue to gather data to bring insight and actions, to UHC. Thank you very much.
Thank you, John, for that great presentation. I don't think we have a lot of time to discuss, but I think we'll have time for about 3 to 5 questions. I'll ask Alex, because there's some questions in the chat box, to present those questions. I'll allow them to, those who have put some questions in the chat box, to ask those questions. Alex, please.
Okay, so we had a question from, sorry, I'm just going down there. Uche Amazigo, hang on, I'll allow you to talk. Please ask your question, Uche. Uche, you're able to talk if you unmute yourself.
Can you hear me now, Alex?
Yes.
Yes.
Sorry then for the delay. Now, Dr. Onoka and the policy group mentioned that citizens lack knowledge, and I agree completely with them. There is total lack of knowledge of the citizens. In fact, their perception, their voice on PHC and particularly on UHC is extremely poor. And I'm wondering whether this group, this panelist, could give us 2-3 points on how to improve engaging the citizens at all levels so that at least they understand and have a little knowledge about what we are talking about. So far, what we have heard yesterday and today, we have heard only from us professionals. We don't know what the people want. We've never asked them in this country in a large scale. We have pockets of research about people's perceptions. But I do know that if you can Google the World Health Organization report, which I shared with Professor Konofor yesterday, a study we did for 10 countries in sub-Saharan Africa in 2012 about their perception of health systems in Africa. Very interesting of what people in rural areas think about health systems in Africa. That sort of study could be replicated here in Nigeria, because for me, a Nigerian though, Nigeria is a multi-country. So if we do pockets of research and then we build our decisions on those pockets of research done in Lagos, research done in Kwara or elsewhere, they are not representative of Nigeria. So my question to this group, if it is communication, if it is focusing on states, how do we get to listen to Nigerians so that at least they can understand what we're talking about on UHC? Thank you.
I think we should keep the questions, and then later on, Alex, do you have more questions so that the presenters will answer at the end?
Yep, Dan, you should be able to speak now.
Okay, thank you so very much to the group coordinators. I was a member of the policy group, so my interest is actually on the presentations by the other two groups. For the research group, in terms of funding, the Central Bank of Nigeria recently made available 100 billion naira for research. That's over 250 million US dollars for research related to the COVID pandemic. So there's an opportunity there. It's a question of us, finding a mechanism to make sure that this is sustained beyond the central bank. But I have a specific question for the multi-sectoral group. My thinking is that, maybe you did discuss this, but I didn't see it in the presentation made. What is the health sector going to do in collaboration with specific sectors like education in terms of developing human capital, or Ministry of Finance in terms of financing health and improving the public finance, financial management system? I don't know whether your group looked at those two aspects of multi-sectoral collaboration. Thank you very much.
Thank you. Alex, do you have any other questions? Otherwise, we've asked. Do you have any other questions in the chat room?
No other questions.
Okay, so I will invite, let's start with Chima. Chima, can you start with any questions that you want to answer? You have a question to answer? If you don't, we'll pass on to John or Tanya. Let's start with Tanya.
Yes, very well, I do.
Okay, yes, Chima, please.
And thanks, Dr. Amasigo. That was, a very brilliant comment around it. When I got to my workplace this morning, I saw two women over 30 fighting, and people gathered. They couldn't even touch them. They were just fighting. And I mean, the fuel prices we heard is increased, and then the electricity prices went up on 1st of September. I felt they wanted to express themselves. They wanted to give their voice out. But they can't speak to the government, and they were now expressing their frustrations between themselves, and that was poor. If they end up in the hospital, there's not much that can be done for them. And I think really people's voices need to be heard. Politicians, political leaders, most of them don't have an incentive to create the opportunities for questioning, and that's sort of that's one point. Secondly, when a lot of these things are being discussed, it happens in Abuja. And those who have access are also politicians, appointees of government, and NGOs that can afford an office in Abuja, that float in Abuja. But the UHC movement can only happen if it is driven at state level, states and LGAs. Government should be about funding, especially where is the money and how can you make it easier and how can you provide technical support to states. But it has to happen at states, and states, that is where it's a lot more possible to hear the voices of people who are real citizens of Nigeria at that level, not up in Abuja, but there's a lot of circulation, and that's where a lot of the documents happen. So at those state levels, I think just like what, like the conversation we're having at the Nigerian Academy stepping up, along with such institutions that appear independent, that can help in creating the opportunity for the leaders to, meet with the citizens, where such voices, it appears neutral. I will want to focus more on that aspect to say that those are the kind of things that we need to create, and is at that level where people's voices can really be heard. And that's the comment I'm going to make, in response to that. I think I've also been given an opportunity to, just a comment or question for what has come out of the other groups. I think from the research, it will be interesting to hear really, what is it about? We had a national policy on health research. Is it, and I've seen so many times, there have been all the research agenda articulated, it's not funded, and in ministries and departments, there's always a department of research. It's not connected to that research policy. It's also not connected to research funding. Is UHC research funding of research to support UHC? How will that flow? What will be our recommendations? Is it a CBN thing, like was mentioned for COVID? Does the Treasury of US drive research? Is it equivalent to what we have as NIH? And even in the UK, why will CBN be the one driving funding for research? Why will it not be domiciled somewhere? Why will it not be NIMA? Why will it not be the National Institute of Medical Research? Why will it not be an NIH type system that understands the issues? Why do we accept everything that comes like that? Is that how we will drive UHC research? It will be good to hear our thoughts on it. Or are we comfortable with just the fact that there's a third fund? Can the 2 million, 3 million drive UHC related research? And are academic institutions really seen, local academic institutions, as platforms through which UHC research can be commissioned? Because like he said, where your treasure is, your heart will be there. If government's funding for UHC does not go to Nigerian government funding, does not go to Nigerian academic institutions to drive UHC research.
Thank you, Chima. We've made the point.
Happen? So
you've made
please,
a very important point about funding.
Just to think about it. Thank you very much.
Chima, can I call Tanya to respond to some of the questions she was asked?
Yeah, I will, thank you. And I won't try to add to Chima's point, because as a non-Nigerian, I wouldn't dare to try to ask why it's accepted, Chima. But what I would say is that I really hear your frustration, and I understand why that frustration exists. And it came up in the group yesterday, and I feel it myself as a privileged guest to conduct research in Nigeria, that there is such an opportunity, there's so much capability, there's so much capacity in research, but there's so much fragmentation, and that there's a real need for some networks, building capabilities, enhancing coordination, having a greater voice, academic institutions having a greater voice in the country. And I can't pretend to be able to say how that should be achieved. And there might be others who were on the research group who could chip in more. But I see that it's an incredibly, an opportunity full of potential. And maybe this COVID-19 drive is part of that. Maybe COVID-19, the spotlight of it, the spotlight on the need for data to address a health emergency can be used to the effect of enhancing the need for networks and investment in research institutes in Nigeria and the network of research institutes. Somebody yesterday in the plenary talked about, he wished that, somebody put a comment that he wished that there was a project in every tertiary institution in Nigeria that would take control for one aspect of UHC. And I mean, I think thinking to Uche's point about how do we hear community voices, I think we hear community voices, as you said yourself, Chima, through state-driven action. I think it's it's not enough to just talk about states, because we need to go beyond the states. That's kind of, if you think about the macro, the meso, and the micro, with the federal being the macro, the state being the meso, the micro, the actual voices are coming from communities. So our window into communities are, yes, LGA, but in fact, ward development committees are becoming increasingly important in driving improvements in primary healthcare. So I think that they're a real opportunity opportunity there to bring board development committees, not just LGAs, into this conversation. But I think, yes, capturing Nigerian voices, using embedded research institutions in states, but having networks of institutions so that there is an opportunity to build capacity and to share learning across different networks is a really crucial part of the agenda going forward. And all I would say to Dan, if you've had 100 billion naira released for research in the light of COVID, welcome to my world. I'm in the UK, we've had 10 years of austerity and all of a sudden we've got all the money in the world to spend, although we haven't yet seen the tax rises.
Thank you, Taya. Can I invite Professor Idoko to make a final statement?
Thank
Please.
you, Friday, and thank you for that very, very important question. Actually, it came up at the presentation. It was not so much discussed, but you know, I think the answer to it is just to reflect back and see what happened to us when we're dealing with HIV. It was a mainly health sector thing, but each of the relevant sectors in the government had health desks, and from this, they had capacities built. They had their programs that would promote, issues of prevention, treatment, issues of HIV prevention and awareness. And then, this happened not only at the Federal Ministry of Health, but was replicated at the state level and even at the local government. And once you have this, if we're going to move forward with UHC, this is the way we must go, to ensure that finance has a desk for UHC, education has a desk for UHC, information has a desk for UHC, etc., etc. All the relevant sectors. And one of the things that I believe happened with HIV and polio, which is now also happening with COVID, is that in the various committees, policy committees, guideline committees, implementation committees, some of these very relevant non-health sectors are brought in so that, there's a semblance of one team working towards one goal and one vision.
Thank you, Professor Ndoko, for that summary feedback. I think we are coming to the end now. I'm sorry, I have a little cold this morning. I would like to, because much of what has been discussed today in this session has focused on government and its role. And I know that as a consequence of this workshop, the Nigerian Academy of Science will be ready, will be willing, and in collaboration with the UK Academy of Science, to begin to mobilize some from our advocacy and knowledge building activity in attempts to address UHC in Nigeria. So I would like to bring in, NECA at this stage. She's a representative of the Federal Ministry of Health, to talk about the potentials for that collaboration and whether she thinks that will be important for the Nigerian Academy of Science to play a role in trying to get government to do some of the things that have been raised here today. Is NECA there, please? Can you please help us about the last 2 minutes to talk about that?
Right. Thank you, Prof. Thank you very much for the opportunity to speak. I think we've had very interesting sessions and very interesting discussions. Just to say that I think you knew I was thinking along that line. Maybe that's why you asked me to speak. So it's also good now that I'm bringing it to the table. So before now, we were planning on a policy dialogue, which will culminate into a UHC summit, sometime this year. And after most of the discussions yesterday, I muted it to Professor Obi, who is the chairman of the Health Financing TWG. It's a national technical working group. So that technical working group would usually provide guidance for that policy dialogue and for the UHC summit. I said, hey, come on, I think it will be nice and very enriching if we could partner with the academy to, host the UHC summit, because some of the things that are coming out from this discussion, from the conference that we're having, could be, brought to the table at the policy dialogue, and partnering with them, we could take a deeper dive into some of the issues that we have highlighted here, and also drawing on from the lessons that we've articulated from these engagements. I mean, for me, it would be a very good strategy to closely and deeply engage with the leadership of the Ministry of Health, as well as other high-level stakeholders within the Nigeria's health system, because usually at the policy dialogue and the summit, we would usually bring all of those key stakeholders to the table. And he was like, yes, that will work well. That he told me he was going to speak to somebody, I don't know. I said, okay, it would be nice to have that feedback such that I can put it as part of the concept. We're just trying to finalize the concept for the policy dialogue and the UHC summit. And yeah, so it will also be an opportunity to get some support from the academy in trying to articulate the concept note such that it captures everything, that we've talked about and what we plan to do and what the country should also be driving on. So I think for me, as the health financing lead in the ministry, I think the partnership is already established. It's just for us to draw out how to move it forward, and I'll take that to my principals. Thank you.
Thank you very much, Neka. It's clear that promoting UHC will be one of the most important follow-up activities of the National Academy of Science going forward, because I know that we have our members very strategically placed throughout the country to play this type of role and ensure that the policy framework becomes right and appropriate for delivery of UHC in terms of what we've described. And apart from just policy dialogue, I also believe that we need to be very active, ensure that whatever dialogue we come up are implemented. And I think Uche Amazigo, Professor Amazigo, who is also a fellow of the Academy, has also pointed out the fact that the Academy can lead in coordinating research institutions and also mobilizing funds. In terms of funding, I want to say that since we are talking about multidisciplinary or multi-sectoral approach, I don't think there's anything wrong in anybody providing funds. I think all sectors, including banks, including private sectors, should be encouraged to provide funds. And I don't think we can necessarily, because we also have funding from international donor organizations. So I don't think we can necessarily, but I think the Academy of Science has a very important role to help to try and see how we can build capacity for people to obtain these funds. Hello? Am I still on? Hello, are you hearing me?
Yep, we can hear you. I was just putting up, this slide sort of summarizes a lot of what you're saying at the moment.
Yeah,
right.
Thank you. Those are the final areas, and I think they will circulate this in due course. What I'm saying is that the Academy of Science, and in agreeing to co-host this particular workshop, was, I think convinced that UHC is an important area. And right now, the Academy of Science is interested in ensuring that it uses scientific methods to enable Nigeria, indeed the African region, to attain the Sustainable Development Goals. And since access to health is one of these goals, I'm very sure that working with the president and fellows will be able to prioritize some of these activities going forward. I want to, on behalf of this meeting, now stop this session and thank everybody for being part of it. This particular session, breakout groups reporting back, and to say that we have opportunity to continue to talk about this. I myself have a lot of enriched. My knowledge has been enriched in so many ways, and going forward, I've been motivated, and I do all of you are motivated to work on this area after you leave this conference. So it's my pleasure to end this session and to thank you all for participating. Mike, I think I hand over the table, the baton to you now.
Great, thank you, Friday. So I think the slide I hope everybody can see was an initial attempt to summarize what appeared to, because a few people had access to the group presentations that you all saw earlier. So this is very much a draft. And if you are familiar with the expression, a straw man, something to get people to think and critique. But the idea was to try and draw together some key high-level issues that have come out of this two-day meeting, partly as a way of identifying issues to carry forwards. While we've heard a lot of detail, we obviously need to have a reasonably focused agenda for any activities that might come out of this. So Alex, I don't know whether we've got 5 or, I know we're in theory at the end of our time. Have we got 5 or 10 minutes for anybody to make any quick responses to these issues here?
Yep, we have until 11:40.
Great. So I think it's just while people gather their thoughts and maybe want to put their hand up again or put a question in the Q&A. So again, this set of 7 points is not, it cannot fully represent the rich discussions we've had. But the idea is that we do have something reasonably concise to take forward. And it's recognized that in each of these 7 elements, they often overlap or intersect. So clearly the role of the private sector is, may span all of the other points. The issues we've just heard about in terms of trying to coordinate research that may be across different universities, and the point was made about not just doing studies in 1 or 2 states. So initial thoughts would be very welcome, and I think the first question was from Uche. So Uche, please give us your immediate reflections. Over.
Unmute yourself, Uche, and then you can speak.
Can you hear me, Alex?
Yep.
Yes.
Okay, great. I'm sorry. Now, just looking at the 7 points, priority areas, I still think that we are, after 30 years of PHC and even more, we have still left in this priority 7 points, we have left the people behind and out of it completely. So I would plead that we find a point where we will emphasize, if possible, the role, the importance of engaging the people and bringing them on board now after 30 years so that we can reset the mistakes we have made in the last 30 years. I don't see the people in these 7 points. Maybe it's hidden, but there should be one of the key points that everybody should see. Engaging citizens and informing them about what, learning from them what they think UHC should be, and communicating with them, the UHC and PHC. This is missing from the 7 points, in my opinion. Thank you, Mike.
Thank you, Uche. I think that's a fantastic point. And I think the intention was there, and I think we can, that would be easy to work into this wording. And I think we'll circulate these slides again, so people have a bit more of a chance to comment, but the most obvious place would be policy and public or community engagement.
And that, yes.
Making sure that they're, as you're suggesting, it's not just pushing communication out to them, but giving them, say, what they think is happening and what they need. So thank you for that. Are there any other
Mike,
points? Yeah.
Can we have a subgroup 8 called community engagement to capture that?
I'm sure that's fine, yes. Yes.
Because it's a very important point. Because I also know that there's something there's a discussion we've not had about communities in all our discourse on on UHC, and that is the role of harmful cultural practices and beliefs, which can actually serve as barriers to people accessing services. The role of beliefs, and I think that that's where education of city communities and other can also come. They have contradicting opinions about traditional versus orthodox healthcare, and it is by engaging communities that we're able to know how that interferes with universal health coverage.
Yes, I think that's an excellent point, Friday. Alex, maybe this is just a time to just give people a minute of how people might be involved in looking at any draft document that comes out, or even earlier than that, commenting on perhaps this list. How would you manage that, Over?
So we can offer opportunity. We can share this after the meeting in our wrap up and with all the participants, and anybody can send through further thoughts. We have 3 people with their hands up as well. Cara was first. Are you happy for me to put her through?
Please, if you can see who's got hands up, please just work through them. Thank you.
Cara, you should be able to speak now.
Good morning, everybody. Thanks for a great set of presentations and discussions. One of the things that doesn't come through in these areas is the whole area of service delivery. So, we often focus UHC discussions about where the money is going to come from. Should it be tax? Should it be insurance? What mix of public sources? But I am kind of increasingly persuaded that what's really important is to get the service delivery side right, and then to pull the resources through rather than thinking about how to allocate more at the top. We've talked about all the sort of bottlenecks in terms of absorptive capacity. So I'd quite like to see something in terms of priority areas around really looking at the service delivery model and picking up on Dr. Uche's point about primary healthcare, and primary healthcare is the kind of engine of UHC, and the need to explore new ways of delivering those services so that they can absorb additional funds appropriately.
We also have Francis next, so I'll allow him through. You should be able to talk now, Francis.
Okay, thank you very much. I very much appreciate these priorities that have been presented, which are very useful. So I'm looking at priority number 2 that talks about agreement of core aims and priorities for universal health coverage. In our policy group discussion yesterday, we all agreed that these agreements, aims and priorities are very much in existence and very, very well articulated. What is missing, however, is the clear communication strategy, or clear and appropriate communication to those who have the responsibility for their implementation, and of course, clear communication to the community members in the languages they will understand, so that they will be able to hold those who are responsible accountable to their implementation. So that's what we are identified as the clear gap here. And of course, it talks about a coordinated approach to that implementation. So for me, I will ask that we rephrase this in terms of getting a clear communication of the aims and priorities of existing policies and strategies on universal health coverage as against the agreement of it as is put here. Thank you very much. Over.
Thank you
Thanks,
very
Francis.
much.
And then there's also Neka who would also like to talk, so I'll allow her through. Then we have everybody. Neka, you can unmute yourself and then you can speak.
Yes, thank you very much. I have 2 comments. First of all, I'd like to allude to what Uche had mentioned, that it appears that one of the things that has resonated in all of our discussions in the past 2 days appears to be missing here, which is around the citizens' engagement, because they are critical stakeholders in their entire UHC discourse. But thinking back again, I'm looking at 4. When you talk about policy engagement, so I'm just thinking, engaging the citizens, could they be embedded within that policy engagement? Because when you're doing policy engagement, you're engaging with several stakeholders. That's that's just my suggestion. I don't know, we could look at that and probably recouch that policy engagement to be able to capture the citizens aspect of it. Otherwise, we could create a separate bullet for citizens engagement. Now to my main point, which is around the data. So for me, I think we can expand further on this because it should be around data generation, data interpretation, and data use for the different levels of stakeholders within the UHC space. Not just the political class, the policymakers, the executive arms of government, and even the people. They are all embedded within this data generation aspect. So I think we could go further to broaden the definition of, or I don't know, couching this point. I think it should be around data generation, data interpretation, because that's also very clear. We need to generate this data and make it interpretable for the critical people who will need to look at it, understand it, and make decisions using the data going forward. Thank you very much.
Thank you. So I'm Alex. I'm presuming that the people who wanted to make comments or questions at this point have been given an opportunity.
Yeah.
Okay. Thank you very much, everybody. As mentioned, this was very much put something up there so that people could comment, and we've had fantastic comments even in that few minutes. So I'm sure the Secretariat, led by Alex and the team, will be inviting people to make further comments, both on perhaps this, if you like, key messages, but also then for those people who've been involved or want to be more involved, perhaps on a draft document that will be prepared with Friday and the Nigerian team at the Academy there. I think we ought to wrap up now and try and keep to schedule. We've done we're pretty much on time, at least for anything that I've chaired before. So I'd just like to say a big thank you to everybody. Obviously there were people who have been involved for some months in trying to prepare this, prepare for this meeting, led by Friday and the Nigerian team, but with the support of the Academy of Medical Sciences team. So I won't be able to thank everybody in person, but a big thank you to that organizing committee who put in very valuable time to get us ready for this. Obviously, a great thanks to the presenters that we had yesterday and today, who I think have really given us great insights, and certainly for me, who's much less familiar with West Africa, into the very real challenges of implementing UHC. We've had great support from our group chairs, who after the meeting yesterday with some of the Secretariat developed the presentations you heard earlier today, and then presented to you so you could get some feedback. And then obviously to the Secretariat themselves, who've been behind the scenes technically making this work, and I think you'll agree with me, it's actually worked remarkably well. I hope everybody's internet connection has allowed them to participate as much as they wanted to. From my perspective, it's gone very well. Just a couple of closing remarks. I think everybody was aware that all of these sessions have been recorded, and certainly the initial sessions and initial presentations will be available on YouTube, and the Secretariat will circulate links to that so that you can share that with your students, your colleagues, or whoever you want to, in case they want to have a look. The whole purpose of this two-day meeting was to really try and catalyze a conversation. I feel we've been successful in that. Obviously, what we're hoping is that it's not a sort of bright burn for 24 or 48 hours and then completely fizzles out. But it was very exciting to hear from Dr. Necker about the idea for a summit, perhaps later this year, and I hope our Nigerian colleagues will take full opportunity to participate in that. So in one sense, part of the job has been achieved in these last 2 days, and I'm grateful for everybody's input to that. Just one small thing on behalf of the Academy. I think many people on this call will be aware, but if you're not, the Academy does offer networking grants. So to have a look out for those. They're reasonably generous. They are specifically for networking. They're not big research project grants, but and they're not by no means limited to networking amongst the people on this call. So it's a very open call. So please, if you're interested, have a look at those. And I basically think that's all from me. So maybe I'll just pass over to Friday to give the final concluding remarks. But it's been a great pleasure to meet you all online, and I wish you all a very pleasant rest of your day.
Thank you, Mike, for that closing remarks. I want to also deeply appreciate the Academy of Medical Sciences in the UK for actually bringing this initiative to us. They actually started it and informed Nigerian Academy of Science, and then we followed up from there. So I also know that perhaps this is the first type of interaction between the Academy of Medical Sciences and Nigerian Academy of Science. I want to, on behalf of the president and of the Academy, thank the Academy of Science for bringing this to us. You know, at the beginning, we thought it was going to be a West African discourse. We thought we would involve countries in West Africa. But Nigeria, as you know, has 70% of the problems of West Africa. So I'm happy we're able to convince you. You can see now that in terms of universal high coverage, Nigeria has some of the most, what I call, daunting problems in our region. So concentrating your resources and efforts on Nigeria. And if Nigeria wins this battle, then I'm sure many countries in Africa will also win the battle. So I thank you, and I do look forward. What is particular, what I know about discourses and workshops of this nature, is not just writing a report and then forgetting about the entire concept thereafter. We look forward to continued collaboration to ensure that in 2 or 3 years' time, this universal high coverage becomes a public policy, comes into a public policy agenda, and our politicians become more nuanced and willing to do something about universal high coverage. So I think that I would work with the Academy of Science to ensure that they prioritize this as part of their work plan over the next 2 or 3 years. And also and I hope that the Academy of Medical Science will join us. We will be working out a number of concept papers, some sort of proposals to ensure that there's a rapid uptick. The Nigerian Academy of Science is a frontline organization in Nigeria, and it's quite influential in terms of its members. And I think we can bring our influence to bear on promoting universal high coverage, doing advocacy, and public health education. Those 2 things are important for us. And for us who are here and Nigerians listening, I want to thank you all. I want to particularly thank His Excellency, Dr. Olusegun Mimiko, who was there yesterday and is still here today, listening to me now. I want to thank him because he's been a champion of universal high coverage. If we are looking for champions of universal high coverage, I think Mimiko is an exemplar. And I know of several others. I remember when I was advisor to President Olusegun Obasanjo on health, he was very, very concerned. This was in 2006 about universal high coverage, and he did so many things for universal high coverage. So people like that can still be brought on board, and it's just for us to inform them, to let them know what's going on. Many policymakers in this country don't know many things about health. When I worked with Obasanjo, that's when I first knew that what he wanted to know was more about health. And once he knew, he was willing to do something about it. So on that note, I want to thank everybody for listening and for being present, and the Academy of Medical Science UK for pointing this very important problem to us. And I assure you that we will not stop until issues are resolved. Thank you very much.